Good evening, everyone. Thank you for joining us and welcome to our Hello Healthy DocTalk presentation on back pain, common back problems, and treatment. It is right about 6 o'clock, so I think we'll go ahead and get started. I want to introduce our presenter today, Dr. An Lee. Dr. Lee is an orthopedic physician specializing in the treatment of adult and pediatric spinal disorders. He attended medical school and did his orthopedic residency at UCSF and completed his spine fellowship at St. John Medical Center in Los Angeles. Dr. Lee is a member of Alpine Orthopedic Medical Group and Spine Center in Stockton, and he's the chief of spine surgery at St. Joseph's Medical Center. We're very fortunate to have him with us this evening, so thank you for joining us. Dr. Lee, I will turn it over to you.
Thank you, and good evening. Thank you for joining us tonight. Again, my name is An Lee, and I am an orthopedic surgeon practicing in the Stockton area with Alpine Orthopedic Medical Group. I subspecialize in spinal surgeries, and therefore tonight I would concentrate my, how do I move forward here?
Do you want to move to the next slide, Dr. Lee?
Yes.
There you go.
I would concentrate my presentation on the common maladies that cause low back pain. So the low back pain is the most common medical diagnosis in the developing society. Approximately 80% of all adults will experience some sort of back pain in their lifetime. And the incidence of low back pain is approximately 1.4 per thousand person in a year in the US, and it accounts for approximately 3% of all visits to the emergency department. We as a medical community tend to unsophisticatedly lump all the maladies involving the lumbar spine to the nuisance low back pain, also known as chronic low back pain. However, there are two different entities, very distinctively different entities causing low back pain. So the first entity is known as axial back pain, also known as mechanical back pain. It's typically poorly localized. It's non-dermatomal, meaning that it doesn't radiate into the lower extremities. It is induced by activities, and the pain does improve with rest. The second entity is known as neurogenic lumbago or neuropathic back pain. It arises from injuries or diseases directly affecting the nerve roots that innervate the spine and the lower extremities. So for the first entity, which is chronic axial mechanical back pain, despite all the advance and the advances that we make in medicine, the pain generators causing mechanical low back pain remain elusive. At this point, we do not have any objective pathology test, laboratory values, or radiographic findings that pinpoint the cause of mechanical low back pain. The diagnosis is typically made by a combination of variables, including the history, physical examination, radiographic study, and provocative testing. So there are three structures in the lumbar spine that are thought to be the main causes of mechanical low back pain. The intervertebral disc accounts for about 42% of all mechanical low back pain. The zygoapophyseal joint, which is called the facet joint, affect the other 30%. And the last category, which is called the sacroiliac joint, it's a very questionable diagnosis, but it accounts for the remaining 20% of mechanical low back pain. In terms of the vertebral disc degeneration, very often that we see a patient coming into the emergency department that has abdominal pelvic CT that shows significant degeneration of the lumbar spine. However, they don't complain of back pain. This is known as spondylosis deformans, which is age-related painless degeneration of the low back. in patient who has degeneration that is accompanied with pain is known as innervertebral osteochondrosis, which is basically, again, painful symptomatic degenerations. And it is thought that the neurosupply in the outer third of the annulus fibrosus contain all the nociceptors from the ventral ramus, the sinovertebral nerves, and the gray ramus communicans are located in the outer third of the annulus. And when the disc move abnormally, it produces pain mediators such as substance P, prostaglandin, interleukins 2 to 8, and tissue necrosis factor, and that stimulate these nociceptors to signal pain from the disc. So to detect painful disc, it is very difficult. We use an algorithmic approach to this diagnosis. We use the history, physical examination, and imaging to confirm the cause of the back pain. And then we had to use what we call provocative testing. In this case, the provocative testing include medial branch blocks, which is basically blocking the facet joints. If that take away the pain, then it's the facet joint. We also do SI joint blocks, which inject anesthetic into the SI joint. And all that's negative, then you proceed to what we call provocative discography, which is a specific test that we perform to diagnose discogenic back pain, also pain, low back pain mediated by the intervertebral disc. And the reason why we do that last is because it is an invasive procedure. As you can see on this picture over here, we place needle into the intervertebral disc, right? When we place the needle, we measure the opening pressure. Then we inject dye into the disc space. And typically we have to inject using a pressure less than 50 PSI of the opening pressure. So we look for two things once we injected the dye into the disc space. First of all, the act of injection, does that produce concordant pain? Also known produce similar pain. If it produces concordant pain 6 out of 10, then that disc could be the cause of the pain. But we also have to have two adjacent discs that when we inject, they do not cause pain, which is basically two adjacent negative control discs. Then we know that that disc is truly symptomatic. The second things that we look for is the morphology of the dye inside the disc. As you can see here, the top disc in this case, which is L23, the dye is confined nicely in the annulus, in the nucleus pulposus without any extravasation. At L34, right, there's a little bit of dye that leaks out at one of the small defects in the annulus fibrosus. And at L45, because of the extensive degeneration, there is no containment of the dye inside the disc, so it extravasates everywhere. Once we have established that the disc is the cause of pain, the treatment is as follows. Non-surgical management should be applied first. That includes physical therapy, anti-inflammatory medications, behavioral modifications, including weight reduction, exercise, and reduction of nicotine usage. Alternative therapies, including acupuncture and chiropractic care, are utilized. The surgical management for the degenerative disc disease, symptomatic degenerative disc disease, include two things. Either we fuse the disc or we replace the disc with a mechanical disc. So the thought is that the disc is the cause of the pain. So, well, if we can stop the movement, abnormal movement of the disc, then we can actually stop in the pain. That constitutes the fusion, the rationale, constitutes the rationales for fusion. Right? So we have anterior lumbar body fusion, which is fusing the disc from the front, 360 degrees fusion, which means that we fuse the disc from the front and from the back, and standalone posterior fusion, where we only perform the fusion from the back. The second paradigm of thought is disc arthroplasty, where we actually take out the disc and replace it with a mechanical disc. So let's look at the anterior spinal fusion. This is a standalone fusion. As you can see in this particular patient, they have a very degenerative L5S1 disc. So we approach it from an anterior approach between the major vessel, which is in this case are the common iliac vessels, and that allows to access the disc space. We took out the disc, painful disc. We place a intervertebral body spacer to stop the movement, and then we apply fixation with an anterior plate. That operation is quite successful in the right patients. At 5 years follow-up, we have seen a 23% reduction in our equestrian disability index. The visual analog score pain is decreased by 40 points. And the satisfaction rate is quite high, approximately 91%. Well, people said, okay, if we do a fusion from the front, it's good, but it still has some movement in the back. So why don't we fuse them both from front and back, making it much stiffer and therefore less pain? Those are the rationales for a 360 degrees fusion. The problem is the posterior spinal fusion part of the front and back requires dissection of the musculature of the back, including the multifidus and the iliocostalis, and therefore it can produce what we call innocent bystander pain, which is basically collateral damages to the musculature. And therefore the satisfaction rate of 360 degree fusion is less. It's approximately 78%. The problem is that we do multi-level more than one, then we just can't do an anterior fusion alone. We have to do both anterior and posterior. For standalone posterior spinal fusion, again, dissection of the posterior musculature is put this procedure at a disadvantage. And the problem is that it's not very strong in terms of stopping the movement of the disc. And therefore, only 66.7% of the patient reported pain improvement with posterior spinal fusion alone. Well, people were thinking about if we fuse the spine, right? We subject the next level to more movement, higher force, and therefore they could wear faster, also known as adjacent level degeneration. And why don't we try to preserve the movement in that bad disc? So the concept of disc arthroplasty came about in the late 90s, and it was very exciting. We thought in the late 90s that would have changed, basically a paradigm shift in how we treat back pain. We thought that by the year of 2010, fusion would be the thing of the past. Well, it didn't pan out the way we thought. So we started putting disc in universally from between 2000 and 2005. And what happened is that the mechanical discs are made out of titanium and a titanium end plates and a polyethylene center, allowing it to move back and forth. Unlike the knee and the hip joints, the vertebral body bones are not very strong. So these discs tend to subside into the vertebral body and therefore causing pain. The problem lies in the revision strategy. As I previously said, to put these discs in, we have to go through the abdomen. We have to go between the major vessels to put these discs in and mobilize them. In the virginal procedure, it's really difficult, but it's not that difficult. It's doable. However, if we do come back for a revision, it's almost impossible to move some of these vessels, and you can end up with catastrophic bleeding. And therefore, I have largely abandoned doing lumbar disc replacement because I do not have a very good revision strategy should problems arise. And the outcome of this arthroplasty is slightly better than front and back fusion, 360-degree fusion, which is 77 to 87% success rate. So the next joint or the next structures in the lower back that could cause mechanical back pain is the facet joints, right? We're also known as the zygoapophyseal joint. And we thought the innovation of the facet joint came from the medial branches of the dorsal rami. Here's the dorsal rami and the medial branches. So the diagnosis of pain coming from the facet joint is done by what we call medial branch blocks, or we basically put a needle around the medial branch nerve and inject anesthetics. Or we can actually inject anesthetics inside the facet joints. And if we do that and we achieve 80% pain reduction, and if we do it, we repeat it twice, and both times it produces 80% pain reduction, then we can safely say that the facet joints in that particular level causes low back pain. So for longer lasting pain relief, one can perform what we call a radiofrequency neurotomy. Right? That's a big, long name for basically putting a heating element in the area of the medial branch nerve and heat it up to 80 degrees. When you do that, you create 1 to 3 millimeters lesion, and that could knock out that nerve and reduce his pain, right? But however, because using the heating element, you can actually produce thermal injuries to the local area and also to the multifidus. So people have talked about the use of cool radiofrequency neurotomy, where they run fluid through to reduce the thermal injury. And they can reduce the heating element down to about 60 degrees, and they can heat it up for about 150 seconds. The problem is that the outcome measure is not that great, right? Basically, they said 50% in pain improvement constitute a positive outcome. That's a kind of a dismal outcome for a treatment. But we don't have a good surgical solution for facet joint pain. So sometimes we do posterior fusion, but because we violate the musculature in the back, they have additional or other pain after the fusion. So it's not a good problem to have. The last structure that occasionally in 20% of the time gets blamed for low back pain is known as the SI joint. The SI joint is the sacroiliac joint. In this, okay, here's the iliac and the sacrum. The articulation here is take form of what we call a nutation, which means that's a rotation of the iliac or the sacrum front and back to each other. It is known as an amphiarthroidal joint, right? In the past, we didn't really believe in this entity because surgical treatment was not very, very successful. So we thought it was a garbage can diagnosis. If we really don't know where the pain's coming from, then we basically blame this joint for low back pain. But nowadays, we kind of start to think about it again. And that in patient who has long fusion all the way to the sacrum, so say from L2 to L3, all the way down to the sacrum, the SI joint could be subjected to abnormal movement, causing back pain. Or in patients who have inflammatory arthritis, such as ankylosing spondylitis, psoriatic arthritis, or gout, they may have inflammatory SI joint pain. So the clinical features for these patients include pain with rolling over in bed, right? So the physical examination constitutes of a 14 finger test, where we take a finger and we push on the SI joint and it causes pain. Okay, that could be it. Or we can do 4 different provocative maneuvers, including thigh thrust, pelvic compression and distraction test. The next one is Patrick test, also known as Faber, which is an acronym for flexion, abduction, and external rotation of the hip joint. And that if that does that produces pain, then it could be SI. And Gaislin test. If you have 3 out of 4 positive provocative maneuvers, then the patient should be considered for diagnostic measure, injected diagnostic measure. Basically, you put a needle into the SI joint, inject a little bit of dye to confirm that you actually are in the joint. And then you can inject the joint with anesthetics and sometimes with steroid. And if it produces 50% pain relief, that constitutes a positive test. The non-surgical treatment include, again, anti-inflammatory medication, exercises, bracing, manual therapy, prolotherapy, which is injecting sclerosing agents around the SI joint, or intra-articular injection with steroid, and also radiofrequency ablation around the SI joint. As I said earlier, in the past, surgical fusion of the SI joint, we used to do it open. And we did a lot of that in Los Angeles, and they were not very successful. So I completely abandoned that procedure together, and I kind of give up on that joint. But recently, they have been using these fiber carbon graphite triangular pegs and minimally invasive pounding it across the SI joint to fuse them together. And some have, some study have shown that the surgical fusion appears to be satisfactory in reducing pelvic pain in the pelvic girdle. The problem is that Kevin Foley, who is the authority in SI joint fusion, indicates that injection pain relief does not predict surgical outcomes. So just because you inject the joint and it takes away the pain doesn't mean that the surgery produces the same result. So the next entity of low back pain is completely different from the first entity. It is known as neurogenic back pain or neurogenic lumbago. It actually arises from injury or diseases that directly affect the nerve roots that innervate the spine or the lower extremities. The common causes of low back, neurogenic back pain are lumbar disc herniations, lumbar spinal stenosis, degenerative lumbar spondylolisthesis, and lumbar scoliosis that is associated with spinal stenosis. So lumbar disc herniation account for a prevalence of 2%. However, it produces a societal cost in the billions of dollars in cost of treatment, cost of surgery, and also loss of work and disability. So an intervertebral disc, please think of it if you will, is similar to a tire in your car. The tire has a rubber component, which is the annulus fibrosus, and instead of air in the tire, the disc has nucleus pulposus. With time, the tire loses its air and become deflated, right? So the disc loses its nucleus pulposus and become deflated and basically bulge out on one side or the other. And then the tires start to rotate or move abnormally, and it causes increase in wear and tear of the rubber component, which is the nucleus pulposus. And now the nucleus pulposus would then prolapse into the defect in the annulus fibrosus, causing disc prolapse. And if you move abnormally, sometimes by just simple twisting and turning, the old tire rupture, the rubber component rupture, and the air, or in this case, the nucleus pulposus would extrude outside into the spinal canal, compressing and displacing the adjacent nerve roots, causing significant pain. And sometimes, with time, the rubber component closes back up, but some of the nucleus pulposus still remains outside in the spinal canals, causing a condition known as sequestration of the disc herniation. But not just the nucleus pulposus and the rubber and the annulus fibrosus herniate, not just soft tissue, but in 8% of the time, you can actually, the disc is really strong, then it just pulled off a piece of bone here, as you can see down here, at the end plate of the superior or the inferior vertebral bodies, causing compression of the nerve roots. These do not go away. It will hurt, and they will remain very symptomatic until you surgically treat them. So the diagnosis for low back pain, the history of patients who have discogeniation start with low back pain first, and then they develop severe, unrelenting unilateral or bilateral pain radiation into the lower extremities. The patient will present with spasms in the muscle, in the lumbar spine. They have positive tension sign, which means that if you raise the leg straight up, perform a straight leg raising test, they will jump off the table. Occasionally, some of the patient may present with sensory disturbance or motor weakness. And if you herniate at the right level, then you can have loss of reflexes. So if you herniate at L5, S1, you will affect the S1 nerve root and therefore causes loss of Achilles reflex. The imaging study for discogeniation include MRI. As you can see here, here's an MRI of a discogeniation where there's significant degeneration of L4-5, and there's an extruded disc fragment, right, into the spinal canal, causing significant displacement of the nerve roots. And if the patient cannot have an MRI, then you can perform a CT myelogram where you inject dye into the thecal sac, and here's a thecal sac, and then you can visualize the defect caused by the disc extrusion in this case. In these patients, occasionally, you may encounter a patient who presents with bladder or bowel dysfunction and with saddle anesthesia. Those are the symptoms of cauda equina syndrome. This is a surgical emergency. Basically, in a patient who has chronic spinal stenosis, the spinal canal, the nerve have time to adapt to the narrowing of the spinal canal. But in an acute discogeniation, they basically have no time to adapt, and they can actually proceed to nerve death. And that, in those patients, it constitutes emergency situation. So if they have bladder or bowel dysfunction with saddle anesthesia, you need to send them to the emergency department to immediately get or urgently get an MRI. And we need to be contacted because they would require surgical intervention. So the non-surgical intervention for discogeniation, including avoidance of activities, weight loss, structure exercise program. Fortunately, 95% of patients with acute discogeniation will experience pain improvement whether we do anything or not after about 6 weeks. So in the first 6 weeks, what do? You're basically trying to control that pain. You give them anti-inflammatories, muscle relaxants, sometimes narcotics. But the most effective medications for them are the metodospecs. Basically give them taper steroid for about 5 days, and that typically reduces the pain significantly. All right, what about epidural steroid injection? If you try all these medications and they do not work, then the patient is a candidate for epidural steroid injection. If you look at these two sentences, what do they really mean? In the short term, high quality evidence supporting epidural steroid injection. Long term, moderate quality evidence. What does this thing mean? All right. So what it means is that in an acute discogeniation, there's two components to pain. One is the rupture of the disc that constitute an inflammatory event that can cause pain. And the second cause of pain is compression. So in an acute period, inflammation is the main source of the pain. So therefore, epidural steroid injection, where we inject steroid into the spinal canal, which is a very strong and potent anti-inflammatory, probably will be successful in relieving the pain, right? If you wait for about 3 months, the inflammation subsides. So the pain is actually caused by compression of the nerve root. So therefore, injecting steroid into the spinal canal may no longer be successful because the pain is actually caused by compression. And for compression, we have to address it using surgical management. So we do surgery by basically performing a small laminotomy on the side here, retracting the nerve root and the thecosac to the opposite side and remove disc herniation or extrusion. You can do with an open or MIS. There are no differences in the outcomes, except for there are more complication with MIS because you don't have a lot of room to work with. So you can injure the nerve and cause dural tear. All right, so the other one is how much disc do you remove? You can remove limited amount of disc that extruded out, or you can perform a subtotal discectomy where you really go in there and take all the nucleus pulposus out. I prefer limited microdiscectomy where I only removed the extruded fragment. And that's because of performing a subtotal discectomy, the patient tends to have persistent low back pain afterwards. With limited discectomy, there is a 10% chance that whatever's left behind might extrude it back out again. However, I would accept that 10% chance to reduce the incidence of post-discectomy back pain. So the spine patient outcome research trial, which is a pretty big trial, short for sports trial. It is a randomized trial with concurrent observational cohort involving 13 medical centers in 11 states. And what does it say about disc herniation? It concludes that patient who underwent surgery for lumbar disc herniation achieved greater improvement compared with non-surgically treated patient, with no degradation outcomes at 8 years. So surgery is better than non-surgery in large extruded disc herniation. For me, if the AP diameter of the disc is between 0 and 5 millimeters, I rarely operate. It's not big enough. If the disc herniation is more than 9 millimeters, then I typically would operate early on those because the amount of compression, they will never get better. The gray zone is between 5 and 8 millimeters. And for those, I typically would use epidural steroid injection to see if I can get them better without surgery. The second cause of back pain is lumbar and lumbosacral spondylolisthesis. There are 5 types of spondylolisthesis. However, the common one that you see is degenerative spondylolisthesis. Right? The primary degenerative spondylolisthesis, as its name suggested, that it is the degenerative changes of the disc. As the disc gets deflated, it moves abnormally. Then it causes wear and tear in the facet joint, and basically the superior vertebral body then slides forward in front of the inferior vertebral body. The most common level that it occurs is at L4-5 in the lumbar spine. Secondary spondylolisthesis occurs cephalad to a prior fusion. So why does spondylolisthesis causes back pain? Think about the spine, the bone in the spinal, the vertebral bones. They're basically a bunch of bone with a hole in the middle. They line up perfectly, forming a tube, right? As you can see, down that tube, the tube contains white fluid. And down that tube travels the spinal cord and the nerve roots, right? So when the vertebral body line up perfectly, the tube is perfectly lined up. Here, as you can see, is a spondylolisthesis between L4 and L5. So when you shift the two vertebral body, you basically pinch off the spinal canal. Right? So here is a cross section of a normal level spinal canal. So this is at L3-4. You can see the thecosac contain white fluid and the nerve roots down below here, sediment at the bottom of the spine. At the level of L4-5, the cross section show that there you cannot see the thecosac at all. You cannot see the nerve root. All you're going to see is thickened ligament flavum and what appear to be a little pinch of a remnant of the thecosac. So the combination of the slippage, bone spurs forming from the disc spaces or the facet joints, and also synovial cysts emanating from the facet joint causes significant spinal stenosis. How do you grade spinal stenosis? If you have good softwares, then you can actually measure the cross-sectional area of the thecosac, but I don't have that in my practice, and that takes too much time. So the way we grade spondylolisthesis is based on the cross-section MRI findings. So for minor or no stenosis, as you can see here, the thecosac is quite large. You can see fluid, cerebrospinal fluid, and the nerve roots are sedimented in this position. This is because the patient is lying in supine. So the nerves is up, basically pulling down at the bottom where the lamina is. In moderate spinal stenosis, we don't see a sedimentation of the nerves anymore, but you can still, the nerves are distributed all over the thecosac, but you can still see a little bit of the CSF right here. In severe spinal stenosis, you cannot see the distinctive nerve rootlets, no CSF, but you can still see a little epidural fat. In extreme spinal stenosis, no epidural fat. So in the previous x-rays, MRI that I show you on this patient has extreme spinal stenosis. For patients with spondylolisthesis, we typically would obtain dynamic x-rays. So we take x-ray in the lateral planes when the patient is standing, and then we perform flexion extension radiographs. And what we're looking for is the abnormal movements of L4 and L5. So in this lateral radiograph, the patient is asked to bend forwards. You can see an anterior slippage of L4 and L5. And when the patient is asked to extend, the L4 then reduce onto L5. So this is called a dynamic spondylolisthesis. And basically the grading of the slippage is based on the excursion of the vertebral body on top of the bottom one. 0 to 25% is grade 1. Grade 2 is 25 to 50%. Grade 3 is 50 to 75. Grade 4 is 75 to 100. And spondyloloptosis is grade 5, which the entire thing just falls off. We don't see these high-grade slip in degeneration or adults. Most likely grade 1 or grade 2 at the most. The higher grade spondylolisthesis are seen in congenital situation in pediatric patients. A patient with spondylolisthesis typically present, some are asymptomatic. Some of them have mechanical low back pain, but most of them would have mechanical low back pain and radicular symptoms, which is pain radiation to the lower extremities. Some of these patients develop severe spinal stenosis, and they can have what we call frank neurogenic claudication, where they would develop unilateral or bilateral buttock, thighs, and calf discomfort and weakness precipitated by prolonged standing and walking. So you see these patients in the grocery store when they bend over the shopping cart to maintain comfort, or they walk around with leaning postures. And that is because when you bend forward and when you put your spine in kyphosis, it opens up the central canal. So the treatment of spondylolisthesis, including activity modification, anti-inflammatory, structural physical therapy treatments, weight reduction, cessation of nicotine consumption, and we also use epidural steroid injections. If the spinal stenosis is not very severe, we can maintain these patients functional for many years with just intermittent epidural steroid injections. But if they have severe spinal stenosis, the efficacy of epidural steroid injections tend to run out after 2 or 3 injections. and they are basically surgical candidates. So what do we do for surgery in patient with spinal stenosis? If a person has a fixed spondylolisthesis or no spondylolisthesis, or if the translation on the flexion extension x-rays is less than 4 millimeters, then you can perform a simple laminectomy as we show here, basically removing the lamina and decompress the central canal. If there is a slippage, dynamic slippage, greater than 10 degrees of angulation, if you see fluid in the facet joint, then you know that they're heading for trouble. And you have to perform a fusion to protect your decompression. So the treatment includes, first of all, laminectomy, and then you perform a fusion. What is a fusion? You basically take bones from the laminectomy, grind them up, and then you put it along the transverse processes and stimulate them to heal so that it doesn't move anymore. It basically stays as one solid unit of bone, so it does not slip. So what are the pedicle screws and rods for? Basically, they are an internal brace, right? They serve no more than just an internal brace to hold the two vertebral bodies together in the correct alignment while waiting for the bone to heal itself. After the bone heals itself, then these implants are no longer of use, but we don't go back in to remove them because it necessitates another surgery. So what are the outcomes for surgical treatment of spondylolisthesis? Walla published in New England Journal of Medicine in 2016, and he concluded that laminectomy infusion was associated with slightly greater but clinically meaningful improvement in overall physical health-related quality of life than treatment with laminectomy alone. Right? So to summarize that, laminectomy infusion in treating spondylolisthesis is better than laminectomy alone. In the sports trial, the cost effectiveness of laminectomy infusion in patients with spondylolisthesis compares favorably to other well-accepted cost-effective treatments, such as total hip and total knee arthroplasties. Right? If you have multiple level involved, then you should perform multi-level fusion instead of single-level fusion, because if you just do single fusion, 4 years later, more revision surgery would be required. So in conclusion, there are two types, two different entities of low back pain. The first entity is mechanical back pain, which is low back pain that caused from the abnormal disc, abnormal facet joints, or SI joints. This back pain normally is mechanical. The patient do not have pain radiculous symptoms, such as pain radiation to the lower extremities. They do not respond very well to surgery. So we try as much as possible to treat them conservatively. The second entity is neurogenic lumbago, where some sort of abnormalities or maladies in the lumbar spine causes compression or displacement of the nerve roots in the thecosac, and that causes back pain and radiculous symptoms. Neurogenic lumbago respond much better to surgical management than non-surgical management. So those are two different entities of low back pain. And with that, I hope that you find this presentation to be helpful tonight. And again, thank you for your attention, and I would like to address any question that you may have at this point.
Thank you, Dr. Lee. We had a couple questions that were submitted in advance. One of them is, what can cause neck pain that comes when you, I know we talked about back pain tonight, but this question says, what can cause neck pain that comes sometimes when you turn your head?
Okay, again, the neck is another part of the spine. So they are built similar to the low back. They have the intervertebral disc in the front and the two facet joints in the back. Typically, the facet joints wear very quickly in the neck. So rotation of the neck means you are jamming these large facet joints, and that causes neck pain and grinding sensation in the neck. So facet pain is much more common in the cervical spine.
Okay. Another question is the use of a chiropractor good if you have back problems?
For low back, chiropractic care is helpful in the first 6 weeks of acute low back pain. Again, in the 95% of patients will get better with back pain, whether we do anything or not. And the problem, it takes about 6 to 8 weeks. All right, so what do we do in those 6 to 8 weeks? We, again, like I earlier said, use anti-inflammatories, muscle relaxant, steroid, taper steroid, physical therapy, or chiropractic maneuvers. And I think that's helpful. In the low back, I don't have a problem with chiropractic manipulation because you really cannot get hurt because it's very well protected. In the cervical spine, however, chiropractic manipulation is concerning because the neck is not very well protected with the musculature, and it could be injured with manipulations.
Okay, a question is, do you recommend ice or heating pad for back pain?
In an acute period. So why do we use heat and why do we use ice, right? So in an acute injury, bleedings occur and inflammation occurs. So when we apply ice, it is a vasoconstrictor. So it stops the bleeding to the area and therefore reduce the formation of cytokines or inflammation. So that's why in the first 48 hours of back problem from an injury, or after you play sports or you dive or you jump off the horse and you develop back pain, in the first 48 hours, ice is very helpful. However, in chronic back pain, we want heat. And chronic mean, more than 6 weeks, because we want it to heal, which means that if we apply heat, it's a vasodilator. So it brings blood to the injured area to bring cells to repair the injury. So ice in the first 48 hours after an acute injury, and heat for chronic problem.
Thank you. Another question is there a way to, it says, what are good stretches or exercises that would be good to prevent having back problems?
Yes. So we'll be core strengthening exercises, right? So first of all, there's two things that you do. One is to maintain mobility of the spine. So gentle stretching, lateral flexion, extension, bending forward without weight in the hands, maintain mobility in the spine. Two is to perform what we call core strengthening, where you do crunches. And why is that? If you think about it, if you think of the spine as an empty Coke can, right? So when you're young, when you play this game, when you stand on top of the empty Coke can, it will not collapse. But if you kick one side of the Coke can in, the whole thing will crumble. Imagine the spine is inside that Coke can, right? You have the muscle in the back, which is a lot of muscle. They're very strong. And the multifidus, and the paraspinous muscle. However, the abdominal muscle, which also contribute to the stability of that Coke can, is in the front, right? It's very thin, right? And in women, that muscle, the abdominal muscles are destroyed because of childbirth. And in men is because of the six packs. And I'm not talking about the six pack that you have, muscle that you have in your rectus abdominis, right? I'm talking about the 6 packs of beer that you're drinking and build up a big old belly. So you really actually have to do crunches to strengthen the abdominal muscle. And if you want an exercise, actually, if you go on YouTube and type in core strengthening exercises for low back pain, I have some really good video on showing you how to do those exercises.
Thank you. Another question is, how do you know if the back pain is something that you should just take care of yourself by taking anti-inflammatories, or if it's something that you should go to a doctor for?
Sure. So, like I said, the prevalence of low back pain is in 85. So 85% of people, adults, will experience some back pain at some time in their life. So if the back pain is making worse with motion, but if you lie down, the back pain goes away, it's typically mechanical low back pain. And that is benign back pain, right? And you can treat that with anti-inflammatories. If the back pain remains persistent when you are resting, right, then you should be concerned and you should seek help faster. If the back pain persists after 6 weeks, then you should also seek help. If the pain is worse at night, right, without movement, and if you have weight loss or fevers or chills, then you should seek help much earlier. But most of the time, in 85% of the time, you can treat back pain in the first 6 weeks with some sort of anti-inflammatory medication, if you don't have those red flags that I just spoke about.
Okay, does anyone that's on the webinar tonight have any questions that they want to type into the chat? I don't see any additional. And Dr. Lee, thank you so much. And Mr. Wiley, I don't know if you know, but he was on the presentation tonight, and he said thank you and great job.
Oh, thank you.
I don't see any other additional questions. So thank you everyone who attended. We will have this up on our webinar, on our website. And Dr. Lee, if is there anything else you need to say?
Not really. So, again, if you have back pain more than 6 weeks, then you should get help. But in the first 6 weeks, without the red flags, you may use exercises, anti-inflammatory, and live a happy, healthy life.
Okay, someone has asked how many ESI can you do?
Well, that's a $1 million question. As long as they continue to be effective, then you can use it for a long time. I have been injecting some of my patients once or twice a year for 10 years and maintain their function, preventing them from the needs for surgery. And I have not seen any significant side effects from these steroid injections. I do not see the systemic side effect of central obesity or puffing of the cheeks like the oral steroid. And I do not see a significant local osteoporosis or compression fracture that was thought that can be the cause of epidural injection. So, so far, knock on wood, in moderate or mild central canal stenosis, I'm able to maintain people functional for many years with intermittent epidural steroid injections.
Great, thank you very much. Somebody says, at what point do you add opioids and how do you dose it?
Yep. So opioid depend on the severity of symptoms. Fortunately or unfortunately, I myself experienced a disc herniation in the past, and it is quite painful. And in those cases, in patient who has acute disc herniation, in the first week or so, opioid use is appropriate. And typically, I would give Norco 10 milligrams every 6 hours for pain. And sometimes they may take upwards of 2 tablets every 6 hours for pain in those patients with acute disc herniation. In chronic problems, discourage steroid use. I mean, we discourage opioid use. So if they have, say, spondylolisthesis and chronic stenosis, we typically uses other treatments such as injection treatments or lesser medications such as tramadol rather than narcotics.
Okay, thank you. Don't see any, can back pain heal itself?
Oh yeah. You know, fortunately for the general population and unfortunately for me, if I had to operate on every single people with back pain, I'd be really wealthy. But 95% of people would, the back pain would resolve. Okay, so the natural history of back pain is as follows. Approximately 75% of people would have intermittent back pain throughout their life, lasting, you know, sometime 2 weeks, sometimes 6 weeks, but rarely requires any significant surgical treatment. In about 10% of the patient, the pains improve. And why is that? Because these people actually take the initiative to change their lifestyle, lose weight, reduction in nicotine use, and exercise, or exercise avoidance of activities that may trigger the back pain. So only 15% of patients who have chronic back pain will end up with some sort of surgical interventions. So you have a pretty good 85% chance of doing better without any kind of significant treatment in your life with such a simple back pain.
How does nicotine impact the back or cause back pain?
Absolutely. I think I put one of the slide up, the sports trial, identify nicotine as one of the major factors, one of the two major factors besides diabetes, you know, or BED, or Quality Disability Score Index, as one major criteria that have a negative prediction on the surgical outcomes, because nicotine affects the nucleus and the annulus fibrosus vasculature, causing significant degeneration, leading to symptomatic discogenic back pain. So nicotine is definitely and well-known, well-established fact that causes back pain, the use of nicotine. Wow,
that's really interesting.
Yes. Yep.
Does anyone else have a question? Do you believe food, is there any healing food like celery juice?
Not that I know of. You know, some food containing turmeric type of ingredient has an anti-inflammatory component and it reduces back pain. But really, I don't know any kind of food that would actually strengthen the back or improve on the biology or the longevity of the nucleus pulposus or the annulus fibrosus. Typically for those, exercise, moderate exercise, and maintain, and weight reduction. You maintain a proper weight and perform exercise. Those tend to maintain the longevity of the disc and the facet joints in the back.
Going along with that question about food, what about any supplements? Supplements are very popular these days, different types. Is there any particular thing that would be good for back pain or preserving the back joints?
You know, currently we do not have a recommendation in the North American Spine Society for what type of supplement. People have talked about the use of, you know, chondroitin sulfate and glucosamine. And when they first came out, it was touted as a drug, a miracle drugs, right? However, and the thought of glucosamine is basically, it's a component in the collagen type 2. So if you take, then that's what causes wear and tear. And if you take that, it will go in and replenish your collagen type 2. It's actually not true. As we know, people have done what we call tritiated GDP tagging of the glucose, the glucosamine. And, you know, they would take the medication, but, you know, when they do, they look at the articular cartilage joint, they do not see the radionuclear material in the joint. So it does not go into repair of the cartilage as we previously thought. Some people swear by it, but we do not have a scientific explanation for how glucosamine affects improve on joint or spine health.
Okay, thank you. We are right about out of time. So